All right, let's dive into a group of bacteria that are, well, literally everywhere. In the soil, in our water systems, they're all around us. They're called nontuberculous mycobacteria, or NTMs. And for most of us, they're totally harmless background noise. But for the right person, they can become a serious problem, creating these really complex and fascinating clinical challenges. Let's get into it. To really get a handle on this, we're going to frame our entire explainer around two key players. On one side, you've got Mycobacterium avium complex, or MAC. We're calling this the rising tide because its threat is actually growing. On the other side, there's Mycobacterium marinum, the steady trickle. It's a specialist, and its risk hasn't really changed. It's tied to what we do, not who we are. Two related bugs, but two totally different stories. Okay, here's how we're going to break this down. First, we'll look at the two very different worlds these pathogens come from. Then, we'll put on our detective hats for the clinical workup, figure out their weak spots, and then talk about the treatment, which is a real marathon. We'll wrap up with how you control something that's everywhere and look at how these infections can cause real harm. All right, first up, two pathogens, two worlds. This is where we'll dig into the fundamental differences in where these bacteria live and the completely distinct ways they make people sick. This table, using data from the Netherlands, just lays it all out. The contrast is stark. Look at the transmission. MAC is something you breathe in from aerosols. Think shower heads or hot tubs. And Marinum, it has to be physically poked into your skin. This leads to wildly different numbers. And the risk groups couldn't be more different. For MAC, it's older folks with underlying lung disease. For M. marinum, it's people with fish tanks. One is a lung disease, the other is a skin disease. They're worlds apart. So what does a MAC infection actually look like in a patient? Well, that's the thing. It completely depends on the host. You have your classic older male smoker with COPD, and he gets this really destructive cavitary lung disease. But then you have a postmenopausal woman who doesn't smoke, and she's more likely to get a much less aggressive nodular form. In someone severely immunocompromised, it can spread everywhere, and in little kids, it often just shows up as a single swollen lymph node in their neck. And that brings us to the really tricky part, the clinical detective work. Because these bacteria are everywhere. Just finding one in a patient's sample can mean absolutely nothing. The real challenge, the art of it, is proving that it's the actual culprit and not just an innocent bystander that got caught at the scene. So for MAC lung disease, you have to satisfy a triad of criteria. There are 3 boxes you have to check, no exceptions. First, does the patient's story fit? The chronic cough, the weight loss. Second, does their CT scan show the right kind of damage? And third, and this is the absolute kicker, you need solid microbiological proof. We're not talking about one flimsy sample. We mean at least 2 positive sputums or a positive wash from a bronchoscopy. You need all 3, or it's not a diagnosis. But now, let's switch gears to M. marinum. The whole diagnostic game changes. It isn't about some complex 3-part criteria. No. The entire diagnosis hinges on one tiny, easily overlooked detail, a single step in the laboratory that can make or break the whole case. And here it is, 37 degrees versus 30 degrees. That's it. See, M. marinum is adapted to the cooler temperature of our skin, around 30 Celsius. But a standard lab incubator, it's set to core body temperature, 37 C. For this bug, that's not just uncomfortable, it's a death sentence. It literally kills it. So a clinician can be brilliant, suspect the diagnosis, but if they don't specifically write culture at 30 degrees on the lab slip, they're guaranteed to get a false negative, every single time. Okay, next up, knowing the enemy's weakness. So we've found our pathogen. How do we kill it? This is where antimicrobial susceptibility testing comes in, and as we'll see, some recent data out of the Netherlands has been a real game changer. With MAC, it's actually pretty focused. Everything, and I mean everything, revolves around one class of antibiotic, the macrolides. Think azithromycin. That's the backbone of therapy. So the single most important question you have to answer in the lab is this bug resistant to macrolides? Because if the answer is yes, your standard playbook is out the window. It's just not going to work. But for M. marinum, whoa, the story gets a lot more complex. Take a look at this data from a really important Dutch study. See that bar on the left? That's tetracyclines, historically a go-to drug for this. A stunning 36% of the isolates were resistant. That's a huge number, and it just goes to show you that you can't assume old rules still apply. And this quote just hammers the point home. If you're practicing in the Netherlands and you just empirically prescribe a tetracycline without testing, you are setting up more than a third of your patients for failure. It's a perfect real-world example of why local susceptibility data is absolutely critical to guide therapy. You have to know your enemy. This brings us to treatment, and the title for this section says it all: a marathon, not a sprint. And believe me, that is no exaggeration. We are not talking about a simple 10-day course of pills here. This is a long, arduous journey for the patient. For MAC lung disease, you're always using a cocktail of at least 3 drugs to prevent resistance. Now, for the less severe nodular form, patients might take that cocktail just 3 times a week. But for the more destructive fibrocavitary disease, it's those 3 drugs every single day, often with an initial blast of IV amikazin, just to get things under control. And if you thought the regimen was intense, just look at the duration. This timeline is mind-boggling. The rule of thumb for MAC lung disease is that you continue treatment for a full 12 months after the patient's sputum cultures finally turn negative. So by the time it's all said and done, a patient is often on these powerful drugs for 18 to 24 months. It's an incredible commitment. Now, for MAC and kids' lymph nodes, the story is actually much simpler, thanks to a landmark Dutch randomized trial that just settled the debate. They put surgery head-to-head with antibiotics. The result? It wasn't even a contest. A 96% cure rate with surgery versus only 66% with antibiotics. This is the kind of high-level evidence that changes practice overnight. The answer is clear. Surgery is first line. So let's talk public health. How do you control something that lives in the environment? It's not like tuberculosis where you can do contact tracing and isolate people. This is a totally different kind of problem, and it requires a different way of thinking. And here's the key point. NTMs are not notifiable diseases. You don't report them to public health because you can't pass them from person to person. Prevention is all about managing your personal environment. For MAC, the advice is a bit general, reduce exposure to aerosols if you're very high risk. But for Marinum, the advice is beautifully specific and incredibly effective. If you clean fish tanks, wear waterproof gloves. Simple as that. Okay, our final section, pathways to harm. How do these infections go from being a manageable problem to a serious limb or life-threatening one? As we'll see, a lot of the time, the biggest danger isn't the bug itself, but the time we waste getting to the diagnosis. So let me ask you this. For M. marinum, what's the #1 thing that turns a simple skin lesion on a finger into a deep, destructive infection involving tendons and bone? What's the biggest driver of that terrible complication? The answer in one phrase is diagnostic delay. It's the failure to ask the right questions. The failure to ask, hey, do you have a fish tank? That delay leads to misdiagnoses. And even worse, it can lead to harmful treatments like steroid injections that just pour gasoline on the fire by crippling the local immune response. That's how a simple problem becomes a catastrophe. And these 2 cases tie everything we've talked about together perfectly. Case 1 is your textbook MAC patient, the older man with COPD. You check all 3 diagnostic boxes, and you start him on that long, daily 3-drug journey. Case 2 is the perfect M. marinum story, the aquarium hobbyist, the biopsy correctly cultured at 30 degrees, and the susceptibility testing that saved him from a failed course of tetracycline. It all comes together. I'll leave you with this final thought. In an era where we've gotten so good at controlling classic contagious diseases, we're now facing this slow, steady rise of bugs from the environment. This quote just captures it perfectly. In an era defined by the retreat of classic contagious plagues, the slow, insidious rise of environmental mycobacteria serves as a stark reminder that the microbial world does not surrender territory, it simply changes the terms of engagement. With infections like these, knowing the new rules of engagement is everything.